Good morning and salam to everybody from London. Uh, it's
Morning.
been reasonably good weather, but today again it's dull and cloudy, but we are in the middle of a summer. So somewhere in London is pretty. I mean, you should come and visit my garden. It's looking beautiful, exotic, all kinds of flowers. Hydrangeas are beginning to come out, which is the best part of it. Then, of course, roses and things. So with those words, let me welcome Shahid. He is my old associate, my right-hand person. He is the soul of Sadiq International Virtual University, the most accomplished scholar. As an ENT, head and neck surgeon, we've known each other for many years. He was superb. Then he joined medical education, moved to Malaysia, and in Malaysia we worked together for some time. Then I requested him to move to Barbados, the institution that I had established in 2012. And Barbados in the Caribbean, in fact, is shining with his glow. He is exotic, superb, and I can't really have no words to express his expertise in medical education. And this is one reason we always enjoy meeting friends and colleagues and educators from across the world. That through Zoom, we can link and talk and have expressions and above all, learn from each other. So today's webinar is a very special one, and Shahid is going to facilitate it. But I'll hand over to Hasnan, who's in Malaysia, an old comrade of Shahid, to handle the matters as a moderator. Over to you, Hasnan.
Thank you, Hasnan, and thank you, SIVU, particularly Prof. Shabi Zaidi and Mubashir, who are the pivotal force in running the SIVU, a huge platform now, academic platform that we all are proud of. And this SIVU has been working in different directions. We have webinars, workshops, courses, book publication, and all have been in one package, and all have been benefited through it. And it is one of the only survival of the post-COVID era where SIVU still surviving, rather with a more huge and more complex makeup that SIVU got through all this tenure of COVID and the post-COVID era. So I'm really thankful I'm part of it, but nevertheless, can't really belittle the role that Prof. Zaidi, Shabi Zaidi has been playing to run this platform and disseminating knowledge skills throughout the world globally, and Mubashir for his being the most important person managing the LMS and the IT aspects of these webinars. And thanks to Hasnan, all this while being the anchor person. So with this, and thank you, Prof. Zaidi, for your kind remarks. I wish my wife was listening that. Gohar, she is online on the other room attending another session. So she couldn't hear, but if recording is there, I will make her listen those words you spoke for me. Thank you very much. You are my guru, you are my teacher, always respected one. That I remember a few of my teachers that I can never forget. You are one of those on the top priority of my remembrance. With this, I move on to today's session given to me. It was a hurriedly arranged session. Thank you, Mubashir, for giving me at least 24 hours to prepare this, but this morning I accomplished it because the journey that I'm taking you on workplace-based assessment will be a new track. It will be an interactive session. Make it interactive with your contribution. That in the middle of these sessions, I may post some questions that you can switch. You can either contribute through your chat box or by taking over the mic. Another aspect of this workplace-based assessment would be, it would not be effectively done if I do not take you on this journey in context of the competency-based medical education, right? So let's begin, and along the line, I will tell you why some of these institutions are still being run on a traditional curriculum or even the outcome-based education curriculum. So what are the differences between traditional outcome-based and the competency-based? I'll make it very clear because since I see I've been teaching on a lot of program globally, and here in Barbados, the medical educationists or the educators should have a very clear concept about all these to practice their medical education curriculum in their respective institutions. So this is the time doesn't permit me to go on, but if the organizers want me, I can give, since I was told this is 1 hour session, but if it is 2 hour session, we can go with the pre-test and post-test. What do you know about the workplace-based assessment? This is not to test you, and I think it will be anonymous, but you can see your performance through the post-test. So I leave it to Hasnan and based assessment. Basically look at work, the task in work, right? So why this has been missing out in our medical education curriculum practice. Many centers have adopted to it, but most of them who have adopted to it are doing it as in a more formative way. But the time should come where workplace assessment should be used for summative assessment, because it goes so well aligned with the competency-based medical education that you will be amazed that at times you will feel competency-based medical education not worth it if you do it in a mock situation where clinical skills labs and other exams, the normal exam that we normally hold in all the medical institutions, is a mock performance test, is never done in a real life world. The assessment, all we do globally is mostly done in a mock situation, be it a classroom test, be it is a OSCE stations. All the patients are used are the simulated patients. Situation created of a clinic is in a mock situation. So considering all this, it doesn't make sense. We are talking of the competency-based medical education, and we are, especially Asian countries, are blessed with their teaching in the wards with the real patients. In Western world, there may be a problem where simulated patients are mostly used, but Asian countries still teaching is guaranteed in wards with real patients without any legal issues arising until now, unless the lawyers contact them and make them aware of what they have been used for is not paid for. So that situation has still not come. So workplace-based assessment, in my opinion, is still one of the blessing areas that we should explore as much as we can.
Prof, can start now.
Okay. Thank you, Hasnan, and thank you, participants. And don't worry, most of the answer you will get along the course of this session. But nevertheless, you will have a post-test to write. And then once you do that, I tell you, anonymity and confidentiality will be maintained throughout. Only a couple of persons would know it who are going to analyze the difference between the pre-test and the post-test and looking at the impact of this session. So with this, okay, we move on to next, which is the brainstorming with the what is the agenda here is brainstorming with the workplace-based assessment background, workplace-based assessment as competency-based education, and types of assessment. Mostly it is used currently for the formative assessment, but the time is coming where, and some centers are in programmatic assessment. Those who have adopted to programmatic assessment actually using workplace-based assessment as the summative. They are doing it formative way, but end of the day, all the results collated over time has been used for summative assessment. So the purpose and the benefits of the workplace-based assessment and preparation, and how would you use it with the feedback in workplace-based assessment, barrier to workplace-based assessment and actions to overcome it, and psychometrics of the workplace assessment, which is a big topic, what will be touched here for your satisfaction to see how reliable and valid you may be when you do this authentic assessment, workplace-based assessment in competency-based medical education. In so many words, the assessment would be competency-based assessment. So demonstration will be the special part of this session. You will make a real sense of what mini CX DOPS 2 model will be used for a demonstration here. Back from 2012, when I was asked to introduce this in University Science Malaysia in the postgraduate program. Okay, so as we go, the learning outcomes, if you see, is here denounced with the cognitive level. So define the competency-based medical education, EPA's workplace-based assessment, Miller's pyramid would be one. Describe the types of the assessment, prepare to practice workplace assessment as the formative assessment, identify the trainee assessor role, demonstrate workplace-based assessment, which is a level 3 of the cognitive Bloom taxonomy or the application, and then discussion, other workplace assessment tools. So I'll introduce to you other assessment tools as well. Okay. So let's begin with, since this is an interactive session, I need your cooperation in this so that I can hear you and we have a good exchange of ideas. So end of the day, when we leave this session, we are well acquainted with the knowledge in a real and the right direction. So what level of the Miller Pyramid workplace assessment tools works at, and can you name few of the workplace-based assessment tools? Anyone can, over to you, Hasnan. If they are typing in, you can read through the chat box. And if somebody
Yes, Prof.
wants...
We have several participants saying does level,
Very good.
And then Dr. Allah said DOPS.
Okay.
Yeah, I think, and then mini CX.
Correct.
Majority of them does level and mini CX and DOPS. These are the comments.
Okay. Thank you very much.
We
At
have
least you are
CBD also.
CBD, okay. Case-based discussion. Okay.
Yes.
You are in the right direction. So I'll introduce a few more. So workplace-based assessment on the Miller's pyramid of the clinical competency is done at the DOS level. Remember, but you might have question in your mind, when we hold an exam, does it really, whether it is workplace assessment or a traditional classroom assessment, with workplace assessment moving from traditional to clinical competence at the workplace, do you think it is at the DOS level? So if you have this question, I'll appreciate sharing with you and also from your ideas, because you might ask, even if the mini CX DOPS, they are done, though they are workplace-based assessment, but patient you use knows that he's used for training. Student knows that this is not the real patient exam like you do it in on a long case, which has become obsolete these days, but I wonder why. Then the task given is in a very typical assessment way. So would you still call it a DOS level? If this question bothers you, we will discuss that as well. So, but until this point, it is done at the DOS level. DOS level. But ideally, I tell you right now, ideally, it is not very easy to achieve this DOS level of the assessment at undergraduate level. Postgraduate, it's very much possible, and we are doing day and night, right? But undergraduate, it is difficult at time. For mini CS DOPS, it's regarded as workplace-based assessment, despite of the fact that it is done slightly, not entirely in a mock situation. But that is something should, if this question arises, we are happy to discuss this, okay? But you have to remember that it is done at the DOS level. So some of the workplace assessment tools are mini CX, DOPS, undercover videos, multi-source feedback, case-based discussion, e-portfolio, and triple jump. I do not know, I like the long cases in assessment. I love triple jump in assessment, which is very much workplace assessment tool, and you should be encouraged to do it. And it's very authentic, and I'll discuss later towards the end of when I deal with the tools. So what do you think? The procedural skills is performed in a clinical skills lab. Will this still be regarded as DOPS? Because DOPS, by virtue of being a workplace-based assessment, is supposed to be an authentic assessment. But my question is, if you perform the DOPS, for example, tracheostomy, your undergraduate will never find a chance to perform tracheostomy. Even the postgraduate student, we have been struggling that everybody experienced doing it at least for once. Then other is the intubation. Do you think an undergraduate will ever be allowed to do intubation independently or even under supervision? So DOPS, when we say direct observed procedure skills, it is direct observed, it is authentic, it is workplace. Do you think doing it in a lab setting would still be a workplace-based assessment? That's my question. So what argument, if you say yes, what argument you will make in favor if your answer is yes? I would like somebody to speak. Whatever your understanding is, let's make it a little more interactive this session so you all will enjoy, because session has been allowed 2 hours now.
Yes, Prof. Yeah, please go ahead.
Yes, can I Shahid Kaisar Sajjad here?
Oh, okay, Sajjad, go on.
Actually, you asked about the intubation.
Yeah.
Regarding the DOPS. But I think in close observation, one can allow to introduce the procedure, introduce the tube, so that the observer can observe the procedure and guide him, or allow him that he is doing or she is doing good.
Okay, I take it in agreement with a pinch of salt. Tell me how many students, just 1 minute, how many students do you have in undergraduate, Sajjad?
Undergraduate?
Yes.
Yes, I mean a 4th year student.
No. How many students in a class, whether 4th year or final year, where intubation
Okay.
Number?
Number is 13, 14.
40, right? No, in the entire class, not in the posting.
Near about 70, 80.
70, 80. But this is very conservative because you are talking of the some of the private institutions. If you are in the government at the public institution, probably you have a number over 200.
Number of 300, 300 and
300,
300,
right?
more
So
than 300.
is it possible to let every student undergo intubation on a real patient? To me, it seems next possible, right? Maybe, as I said, you can do it in postgraduate, but still, we have been struggling to have this for every student. So this is your take. Anyone else?
Yes, I can. Can I speak?
Yeah.
Yes. So DOPS depend upon what have you been teaching to your students in the small group class. For example, in I'm orthopedic surgeon, so we teach how to apply plaster. So that's also DOPS. So how to apply the Thomas splint, how to apply cervical collar. So that can be assessed and considered as a workplace-based assessment. Thank you.
Okay. That you have talked from your point of view being an orthopedic surgeon. I'm talking of the undergraduate program with a curriculum where intubation and tracheostomy is one of the mandatory skills to be learned, right? There are many skills, no doubt. For example, IDL, another in ENT. You can do examination, history taking, physical examination. You all can do in setting, but I'm talking, can you do all the procedure? So I'm sure we know what constraint we have. Now, I ask you to watch this.
Sorry, Prof. Just few comments in the chat just to summarize. Majority of them I said no. And if it's directly observed by trained professionals, then yes. But usually done on a real clinical setting or real patient.
Yeah.
So this is
because
just to summarize.
we couldn't talk from our perspective of our discipline-based skills. We are talking in general about the undergraduate curriculum, right? So just watch this. This is DOPS at the postgraduate level, because we were struggling for them to have intubation. They were sent out to the emergency posting for 1 week, and in neurosurgery 1 week or 2 weeks to have tracheostomy and this procedure done. But the two settings, the emergency setting and the neurosurgery setting, had their own trainees. So our trainees in ENT couldn't find a chance to do it. So we have adopted to this. So just for this, a student has been given this is back in 2012. This student now doing is already associate professor.
This from the right side from the teacher's note, then push the thumb towards the left side, and then further go inside until.
So he's performing and he's giving a running commentary, right? And he is observed for this procedure.
And to visualize the parts. So once I visualize the part, I will insert the end. So after insert, then I will set as far as about 20 sides. So I will connect integrated to the and back. And check.
So okay, let's stop at this point and then look at the feedback, the immediate feedback, which is
okay. Very well done. Well done.
So if you cannot hear, I'm appreciating in the first place that the feedback should be for his doing well, the aspects, then sandwich with what he couldn't do well, then giving him a nag of it by demonstrating.
Started up, you didn't do the oxygenation of the saturated.
So I'm telling him that when you started up, you didn't oxygenated him in the first place. You should have done it before inserting the tube.
Back, right, and the mass. Doing a section of suction being in your mouth and any saliva or anything amount you should pursue. That said, that you will push the time to the left. No, it's time not push to the left. You introduce your
Prof, you are muted. You need to unmute yourself. We can't hear you, Prof.
The host wanted me to be unmuted.
Yeah, please go ahead. You were muted just now. You repeat what you were saying.
Okay. So this is the feedback. This is the feedback. So this was the feedback to move forward. So this is a very much a mock situation, but docs. So if this meeting is being recorded, leave meeting. Okay. Should I click OK?
Yes, you can
Because
say okay.
beside is leaving the meeting. I hope I'm not leaving. Okay. Anyway, so clinical skills lab procedure can be utilized to conform training in context of competency-based medical education to promote skills and confidence of the trainees. So it will complement, no doubt, but complement to the extent where they will feel the confidence to do it when their time arises and they have to do it in a real patients. So keeping with the patient safety, as there is less likely chance available for undergraduate students to perform intubation on real patients. So this question has been asked time and again in various forums, whether those done under the mock situation in the clinical skills lab, certain procedure in workplace-based assessment, are they still regarded as workplace-based assessment? The answer is yes. And you have witnesses. So there always has been some compromise in assessment. Whatever, if the classroom test is done or in performance test is done, there is some compromises all over in assessment. So this is one of those. Okay.
Prof, there are two comments in the chat, and Dr. Mavia raised hand. Just to read the comments, like I think first one you already answered, like they were saying like doing the skills lab on dumbing, still we can call that as DOPS. That's
Yes.
and second one, Dr. Salim have raised this concern ethically, like normally we don't ask students to intubate. Yeah.
That's right. That's a comment. I agree with that. And
Yes.
then, but don't try do it all the skills procedure that is done in traditional assessment, where you can use authentic patients to be performed on. Right? Don't do that. Intubation, tracheostomy, and procedures like this is less likely chance students will get. You can do it in a skills lab, but not do those tests. For example, indirect laryngoscopy, they can perform in on real patient. For example, examination, palpating the thyroid, auscultating thyroid, and all these, you can do it in real patients. So don't do it in a mock situation on a mock patients, right? So where the opportunity is given, do it in real patient. Now, quickly moving on from
Sorry,
traditional
Prof.
to
There's
yes.
a raised hand by Dr. Mavi Ahmed. If you can
Yeah.
unmute, or I don't know what you want to say. Please.
I have two questions. Can we
Yeah.
regard skill lab an authentic or a workplace location? Because we are controlling everything in the simulation or in the skill lab. So can we regard it workplace? The other question, what about authentic? Is it a criteria for workplace or not?
Okay, thank you for these two questions. First, we have been debating all this while that a competency at a clinical skills lab procedure at times where you cannot do it in authentic. The word authentic means real patients, right? So authentic is real. So when you cannot do it, you can do it in a skills lab, at least to expose your students to these procedure, to learn in a mock situation, yet gain the skills, yet gains the confidence to do it when the time arrives to do it in real patients. So they will not be shaky, they will not be hesitant to perform it. But those procedure which you do not get opportunity to be performed on real patient at workplace, you can do it in mock situation. It still will be regarded at workplace. But nevertheless, remember one word, it will complement your authentic learning. It is not authentic learning. So with that remarks, I move on. So knowledge, I hope I have answered your question.
Shahid, can I just ask you a secondary question with this regard, what you have answered?
Yeah.
I just want to know, just to improve my knowledge, that if somebody have a better skill in the skill lab of introducing introtracheal tube, but can that students can perform this in a real patient?
Okay, it's a very good question, but being a medical educationist, I would say no. Why I would say no? Because you have to have equity for all the training. If you choose one or two students, this will be bias, right? You are depriving others from the real procedure, and you are choosing one or two whom you think have learned this procedure nicely, can be done. So that's not equity in terms of practice of the medical education. Am I clear, Kaisa?
Even no, even then, I guess, or I confirm that the Mr. A B is doing very good in intubation, so I allow him to do intubation in this patient or any other patient.
That's what I answer, Kaisa. That's what I
I mean,
answer.
this
So
is not.
what about C and D?
Okay, but C and D is not, in my opinion, is not good in the skill lab. So I'm not
Okay.
allowing him.
Okay, wait a minute. This is very good question, Kaisa. Very good question for the brainstorming. I'm taking this workplace assessment and making it interactive, and I'm so glad that you all are interacting on a journey with competency-based medical education. You know, you are saying A and B are very good. They are good learner. They are fast learner. But C and D are slow learner. They couldn't gain it. Who is at fault?
Yeah.
The student or you?
in my opinion, I think students are not
Your laughter
C and
tells
D
the
is not
story,
taking.
right? Yeah, your laughter
Yes.
tells the story, right? So competency-based medical education, every student is your responsibility. An ideal competency-based medical education, we shouldn't move forward in like we are doing now. 70 pass, 30 failed, move on. No, those 30 fails, they do remedial pass, move on. No, those 30 who are not competent is your responsibility. This is what the onus is taken in competency-based medical education with the help of workplace-based assessment, that every student should learn have minimal competency which is required for the community practice and the safety of the patients. Am I clear to my answer to you, Kesa?
Yes, it means that they all will allow to do the intubation in their house job, in their training, isn't it?
Yeah, correct. When the time comes, those who have learned well, they will be good performance in internship. They will be good performance in residency program, and they will get their chance of doing it on real patient in postgraduate program. So they have to wait until that time, right? But giving one or two student opportunity based on, you see, we will come to that. This is criterion versus the norm references, right? We are not competing one student with the other students. We are competing for the minimal competency acquired by all. If we do that, then we are practicing norm reference, right? We are segregating the good students who have good skills in mark situation can be allowed to see the to perform it on real patient would be something which in medical education would be questioned, right? Why is it'll be little biased. So coming back to
Thank you very much. Thank you very much, Shahid. Thank
welcome.
you.
So process-based education, knowledge acquisition versus knowledge application, right? In traditional that we were trained with, Kasa Sajad, you and all, we were, though you were junior to me in the same institution, but we have taught through the same program of the traditional curriculum, right? Their knowledge acquisition was guaranteed, but knowledge application was not guaranteed. Then single subjective measure, usually one or two long cases and there we have now OSCE with multiple station OSCE, so multiple objective measures. Giving the example so that concepts is clear here. Norm reference assessment versus criterion reference assessment, right? In norm reference assessment, one students would be compared with a characteristic feature or would be compared one another, like in grading, right? Excellent, good, pass, fail, and all. But here in competency base is the criterion reference. If one has to learn intubation, whether in the mock or in the on the real patient, he must learn it, and somebody should sign him off. So it is my duty as an ENT surgeon under me. If there are my posting, there are 10 students, undergraduate students, all 10 must be equally learn how to do intubation with the minimal competency. So criterion reference of assessment, that is minimal competency to be achieved, not comparing one student from the other. Then evaluation setting for continuing quality improvement. Normally, our time, the evaluation was not done based on the performance of the assessment. The student would take, here evaluation is done for improving on every moment we move on with our curriculum. So then in traditional emphasis on summative assessment, here emphasis on formative assessment in competency-based. In competency-based medical education, the boundaries, I have been telling you before in my sessions in postgraduate program, in I think it was in the certificate program, that the boundaries are almost dissolved between summative and formative assessment when it comes to programmatic assessment. Because formative assessment, the biggest question is, if it is used for decision-making, it is not formative. But in programmatic assessment with workplace-based assessment over the training time, it is done multiple times. Tasks would be done, and then their performance is documented. And another team who is not part of the training team would decide on their performance given or rated by the supervisors. So that kind of formative assessment, not really at the point of the time when it was done, was used for decision making, but later on Collated formative assessment can be used for summative assessment. I hope this point is clear, right? So now I'm taking you through this infographic that I had developed for you. This is the first one is the curriculum in a traditional way. So curriculum, teacher decides on content to teach. So when our time, the medical school was opened up, a team was formulated, a team would come, sit together and decide on curriculum, right? Not looking at the students' need assessment, not looking at need analysis of the community or the locality where the institution is built up. Now, after the curriculum decided, education objective was decided. After the curriculum decided, educational objective, right? So what teacher would deliver, not what a student will learn. That's what the difference, right? We were taught through this curriculum. Assessment, subjective, what teacher decides to assess, right? And the outcome is learner receive scores and grades. So we have debated a lot in my postgraduate diploma program. A 50% passing marks, do you justify a person in medical education to be 50% passing mark, to be in a very uncertain position? 1 mark less, he's failed, 1 mark over, he is passed. So would you allow them? So that kind of 50% or 60% passing mark was the outcome. So 50%, that 50% they have the competency and 50% they don't have the competency, but yet they are passed, right? Now coming down to outcome-based education. Now I'm taking you slowly through traditional to outcome-based and then competency-based. In outcome-based, what happened? There were certain changes. Curriculum need assessment, right? It was not the discretion of the group of the teacher who would decide on curriculum, but what curriculum need assessment is done, need assessment at the community level, need assessment, need analysis at the students level. And then learning outcome was decided, not learning objective. Objective is what teacher wants to teach you, and a learning outcome is what a student will be able to perform after the training. So learning outcome was decided, then was the assessment came into picture, and then teaching learning strategies, which of course was one-way traffic. Teacher would be teaching, learner would be learning, and then they were graded nevertheless through the scores, but with the constructive alignments. Constructive alignment is, for example, you have 5 learning outcomes in a course. We would see that all those 5 learning outcomes are achieved. But these 5 learning outcomes achieved are more implicit. It is not explicit. Now I'm using word implicit and explicit here, right? This is the difference between competency and outcome-based education, where most of the educator would be, or the medical teacher would be a little not clear what the difference the outcome-based education and competency would be. So here learning outcomes are there, but they are implicit. With 5-fold learning outcome, all the procedures students achieve or not would be decided on. Now I'm moving on to the competency base. Here, health system community needs assessment, need analysis is done before you develop a curriculum or open up a medical school. The competencies outcome are not the learning outcome, but the competencies learning outcome. So the competencies are decided on the basis of the skills. For example, in ENT, we have 15 skills that every student should learn, right? In traditional, we were testing them on 1 or 2 and passing them. The rest 13, whether they did well or not, are the lucky students who have done those 2 procedures. We have checked them in assessment, and rest 13 he has done, still he will pass. So the competencies are identified. Each competencies, they must be observed for performance, right? So those competencies are then translated into EPAs. Now I'm moving you gradually from the tasks or competencies to EPAs. So those competencies are defined or translated into EPAs, right? Entrustable professional activity, right? So this activity, every student has to perform, and a supervisor has to sign him off. It's not about the score. It's about he has achieved minimal competency or whatever competency was set for that. Okay, I'll give you the rubric in a moment. Now, next was after this assessment, demonstrate EPS. They have to demonstrate each EPS, not in a classroom test. On a real patient or where the real patients are not available, we have moved from that discussion to mock situation where some of those workplace-based assessment would be allowed. So demonstrate EPAs at workplace. So those tasks, so now let me make it very easy for you to remember, because what we learn in this session, we forget. So EPAs, what is EPAs? Simple. In traditional way, it is task. In outcome-based education, it is competency, right? And then in competency-based, it is EPS. So what is EPS? EPS is task in work or task during work. So that becomes your EPS, right? Now, next we move on to the competencies. There has to be entrustment of those competencies, and this will come from the milestones, okay? So I'll talk on milestone in a moment. You can easily link up EPS with the milestones, right? Then curriculum, how learner will learn, it's a two-way traffic. Teacher, learner, both are responsible for their learning, not teacher alone, right? I hope this is clear at this point. And when I give you some of the examples of the EPS and milestones, then it'll be more clear. So what is the difference then between now traditional is out of our scope now. Now we are debating between outcome-based and the competency-based medical education. So the outcome-based outcomes expected of a trainees are made explicit in competency-based medical education, and it is implicit in outcome-based education, okay? So curriculum is designed to practice around the 4 elements. Number one, most importantly, first of all, you have to spell out, you have to speak out or mention your explicit expectation from the students in undergraduate program at the level of their training. Then you observe them, right? So you observe them, observation, then you provide them feedback, right? After the feedback, there is a coaching. Feedback not alone. If they have something to perform, they are not performing well, you have to coach them, you have to demonstrate, as I showed you one of the intubation clip just now, right? And then you assess them, right? So you observe them. So for example, how many schools do really bother to take on the intake in year 1 the level of their understanding with the medical practice or with medical education they are undergoing for next 5 years? We ideally should have some preliminary tests at the intake point, right? And then we keep repeating it with the level of training until 5 years, and you will see there's a lot of changes, keeping almost the question around the same. So observation. So once someone enters a program, you simply observe them. For example, you ask them to take a history, communication skill. I mean, history, they are coming from the pre-university school training, so they will not know what is history taking for the patient, but communication skill, you can always observe them for communication skills. So you observe, but you do not give your input. You just observe, and then you put down their performance in communication skill at that point of entry into medical education program. Then you give them a feedback, right? This is how the communication skill you need to improve on, right? So this is your feedback, and then you coach them. You take them to a clinical skills lab, you use a simulated patient and perform on them those EPA or the task, right? So you coach them and then you assess them in a real life situation, which is authentic assessment, which is workplace-based assessment. So observation, feedback, coaching, and assessment is the 4 pillars of the competency-based medical education, right? And it's our responsibility that every student entering into the program achieve the minimal competency. One may be better than other, but minimal everybody should achieve. That's our responsibility. So competency-based medical education is an outcome-based approach to the design, implementation, assessment, and evaluation of a medical education program, right? It is a very organized program, and competencies must be carefully defined, measurable, and related to knowledge and skills. It's very important that competency that you design must be measurable, not that you have a competency, but you do not know how to measure it, how to assess it. Okay? And I'll take you through those competencies as well. But at this point, some of you might be having a little struggling with what is the difference between competency and competence. Can anybody tell me? What is the difference between competency versus competence? I'll make things easy for you. I use 1 or 2 words always to remember forever. So EPS is task in working. Task in working is EPS. What is competency versus competence? If not, I'll move on. Competency is the task, is the skills, right? Task or the skill is competency. Demonstration of competency is competence. Now I'm giving you a single word definition, right? 2 or 2 words definition. So competency is the task or the performing skills, and competence is demonstration of the skills. Okay, so intrustable means practitioner has demonstrated the necessary knowledge, skill, and attitude, and you capture that in your rating or assessment. EPS must be observed, and these are observed through milestones. I'll introduce in a moment. Milestone. I'll not take you through competency-based medical education because I have to move fast to the workplace-based assessment. So some countries like Canada, like USA, ACGME, GMC, UK, and Australia, and a couple more have developed their competencies framework, but every other medical school is struggling to develop it. So I would suggest that you move on with adopting to one of these, depending on your curriculum. For example, in Barbados Medical, University of American University of Barbados, we have adopted to ACGME, right? ACGME is American, Graduate Medical Education, Accreditation Council of the Graduate Medical Education. They have 6 core competencies. Under each core competencies, they have several sub-core competencies. So we have adopted to it because most of our students are competing with the USMLE and competing for residency program in USA. So we have adopted to our core and sub-core competencies from ACGME. So the 6 core competencies, each of ACGME, and GMC also has the 6, but CanMed has the 7 role of CanMed competent physicians. So you can adopt to these if you do not want to be struggling with your own, but if you have your own is better. Each of these competencies will have EPAs and milestone achieved at various stages, and the progress of resident must demonstrate achievement of those EPAs through milestones. So what is milestones? If you have a basket, that is your EPA. Within the basket, you have multiple items that are your milestones. So milestones will be looking at your EPAs, which your tasks, a defined task or task that they have to do during their workplace is the EPA. And then in that basket of the EPA, there are multiple milestones. You will be using to observe them. For example, history taking at year 1 would be different from history taking, would be very complex in year 4 and 5, right? So the milestones will change over the level of their training. At the same time, milestone will also change at the level of their attainment, right? So this is very important, what attainment they have acquired. For example, I give you a rubric for this was the CanMed, right? You can adopt or you can develop your own, but the CanMed that we practice, we partially take the learning outcome from the ACGME, and CanMed we practice for the attainment of those EPAs. So for example, observation but no supervision. I gave you an example, right? Entry point, no, just observe, no execution, meaning no coaching, right? Execution with direct proactive supervision. Then in your program, you know, there will be a session for them to learn, for example, indirect laryngoscopy in ENT, everybody has to learn. So there has to be a proactive supervision on their learning, right? After they have learned, do you want to test them? Want to bring them to a real patient or in mock situation for dogs, for example, on an intubation or tracheostomy, then execution with the trainees reactive supervision. The students will approach you and they say, I have mastered this procedure, can I be observed? So this is reactive. Proactive is one which is in the program and everybody has to undergo that with a demonstration of those skills. But reactive, when they have learned, they will approach and they will be Most of the workplace assessment in DOPS are done on the request of the student. Mini CX is done randomly. When interesting patients comes in the clinic, you can call upon those students who are under your training to do mini CX. But DOPS, we usually ask them, when you have mastered the skill, approach us. Okay. So level 3 will be reactive. Level 4 will be supervision from the distance or post hoc. So you let them know, like postgraduate program, we let them perform with the real patient. We do not go enter and tell them, hey, you are not doing. For example, I'm watching in our post-graduation program, we watch our postgraduate students through their performance through the video recording, right? We go through those video recording and then we observe their shortcomings and then we supervise them. So this is distance supervision, right? Then supervision provided by trainees to junior. When they attend a level where they can teach their junior, so peer teaching is very important nowadays in medical education. So all these concepts I'm bringing into your knowledge to move on from your traditional curriculum to at least outcome-based, if not then competency-based, right? It's easy, I tell you, but your faculty has to work hard. There has to be a well-organized faculty development program. So these are the 4 stages of the undergraduate level, which is well developed. This is not developed for the undergraduate, mind you, for the graduate program. Graduate, which is residency, right? So residency is a graduate program. It's not undergraduate program. So they learn, and when the resident pass out, they are actually postgraduate level attainment of the qualification. So in CanMed, these are the 1, 2, 3, 4, 5 level of observation, which are called the milestones. So now I think the EPAs and milestone concepts is very clear to you, right? Now, moving on to SAGME core competencies. For example, 6 core competencies, they have patient care, medical knowledge, system-based practice, patient-based learning and improvement, professionalism, and interpersonal and communication skills. And on the right side, you see patient-based care, history taking, physiotherapy. There are so many of the sub-core competencies that you can choose and develop for your own curriculum. Then you have to see each of the competencies that you have developed for your undergraduate program. How do they match with the core competencies, right? These are the 6 core competencies. Every single competency will not address all the 6 core competencies, but overall in a program or a course, collectively they will achieve. So these are the mapping, right? So now let's move. Time plays important role in training of the education. 2 questions coming again to you for your brainstorming, right? I'm making this interactive, and I'm so happy that you all are interacting. So is it possible to achieve competence without changing the time frame? Remember one thing, postgraduate program, competency-based medical education has been achieved in most of the elite institution, if I say not all, right? Most of them have achieved how to run their program on competency-based medical education at postgraduate level. Undergraduate, still many developed countries are still who have advanced to a high level of medical education practice are still struggling with the practicing competency-based medical education at undergraduate level because of the few reasons. Number one, for example, if I had to tell you, competencies are very generic in undergraduate. Competencies are very well defined and determined in the postgraduate program. The time span may not be a question in the postgraduate program, but you know your curriculum for MD or MBBS is 5 years, 4 years, whatever it is. A student have to finish within that. Then there are multiple competencies. So 2 of my question here would be: is it possible to achieve competence without, I'm using what competence, right? Mean demonstration of the competency. So possible to achieve competence without changing the time frame, and can all competencies be demonstrated within a specific time? For example, when you give your every discipline to define their EPS, you will be surprised. ENT, which is considered a minor, we have came out with the 42 skills that a student have to learn, right? 42 in ENT, right? Now, is it possible if internal medicine and they come up with 100 of these skills and you can finish it in 5 years' time? So these are my two questions, which I may not be seeking answer right now, but you can think on your own and can answer this in the chat box or later. So this, if achieved, will make a good system of competency base even a better. But this has been achieved by CanMed using a competency-based design. Competency-based design is a design of the competency-based medical education, whereby they have implemented it in the residency program. So moving on from here, so now you have understood that how important in competency-based medical education is to have an authentic workplace-based assessment, right? So I'm not taking you typically how do you perform the workplace-based assessment, but what I have tried is here to open up your thoughts for competency-based medical education and its alignment with the workplace-based assessment, why in competency-based assessment, we need workplace-based assessment, right? Because it's authentic, it's on a real patient. So it's a critically observed competence put into practice. And this, I have been struggling how to define this in one statement. So I could define it: workplace-based assessment is a critically observed competence put into practice, and it informs you how physician performs in a real world clinical encounter and how they can be helped to improve his performance, right? This is workplaces, because feedback is very important. Room for improvement is very important. Remember, when I move along, previously checklist was used. Now checklist has become less important than the comments made by the supervisors. I'll give you an example of that, and then I'll give Hassan also. We have been working on this model to make to produce a digital tool on students' performance, both in competency-based education with the checklist and with the comment. I'll show you that also in a moment. So it's not yet over. So work is on, and perhaps our book soon will be mentioning all those. So workplace-based assessment is not the same. How learners' performance is assessed in examination, right? Is not the same. Exam, you know, is held in a mock setting that complements the learner's performance of authentic learning. It complements, right? It doesn't really is observed on real patient. So exams are important to mark a student's knowledge, but nevertheless, exam is very important. We can't say we can't hold. I have always been thinking, when I become a vice chancellor of any university, first thing I'll do is to do away with the assessment, so that students' nightmare of assessment is over and that they can focus more on learning. Now our curriculum for students is assessment. Our curriculum for teacher is different, for student is different. These points I'll keep telling you for your brainstorming. So exam are important, nevertheless, not because higher education wants it or accreditation agencies want it, your institutions want it, because you want to know the student progress as well. You want to know how, you want to have feedback on your teaching as well. Okay. So workplace assessment focuses on critically observed important activities, and process involve experts watching someone. It's not like PBL, a librarian can come. When the PBL was introduced, it was said that even a librarian can run a PBL session, right? Then it was caught with a lot of criticism and all, because it was later on established when a PBL is done with a trained clinician is much better than when it is done with an untrained clinician or irrelevant. So similarly here, experts watching, if say I'm a medical graduate and I'm asked to watch an orthopedic patient, it will not be really a good observation that I can make. So experts watching those skills. Workplace assessment on cutting edge of the pedagogy further ensures that the supervisor watches them achieving those skills with minimal competency, and then what are the rooms for their improvement is really focused and mentioned in the comments which they have to overcome in their subsequent jobs or other mini-CX. So take a minute and think over, give your opinion. Is the curriculum we are practicing is a competency-based medical education? So Hassan, you look at the chat box, or if somebody wants to speak, can speak.
No, no.
Over to you, Hassan, for a while.
Yes, Prof. Please, those who want to comment or speak, raise your hand and I will allow you to.
How many
Will-
of you are practicing competency-based medical education? Can I move on, Hassan?
Yeah, I'm just waiting if anybody can comment in the chat. Okay, move on. Yes, please.
Okay. So it looks many of us are not using it. If I say none of us are using it, so but there are schools who are using it, right? Provides feedback. So the purpose is to provide feedback, an area to improve learning, encourage reflective practice, which is very important in learning. Reflective practice is important. When they observe, they have to go back and reflect on their observation, right? This is important. And those observation, those reflection, if needs feedback, has to be immediately provided by the supervisor. So this is mandatory. Besides the feedback, reflection is important, provides a reference to review level of the competence, right? So the rubric you have to decide on at faculty level. Support learners remedial and targeted training, right? If they lag behind, so it's not a remedial exam. For example, I always give an example. In many institutions, I was the examiner, external examiner. When I went there, the students who failed, I was asked to stay back until 6 or 7, because those students who failed will be taking their remedial. So now imagine a student who failed after 5 years of their training in the program has given few hours to prepare, come and do the remedial. Is this justified? And then what assessment are you using in remedial, right? Randomly asked questions. It's a table viva kind of thing, external seats, internal seats, and they are. And then we are doing remedial after a week or 10 days. And then 5 years he failed, but 10 days you are expecting him to pass, right? These are unrealistic and a lot of compromises in assessment, in competency-based medical education, in competency-based assessment, in workplace-based assessment. It is done over time and again, multiple time it is done. The data is collated, and curriculum and the assessment committee will review, which is not part of their training, will review their performance over time collected data as a formative assessment, and then on those a decision is made, right? So that's ideal way to do and move forward. Okay, so now going on preparation. So very quickly, patient consent and safety is the assessor's priority. It shouldn't be like that. With undergraduate, we have all moved to competency to workplace-based assessment, and we hand over our patients to students who are not trained to do whatever the training they had to harm the patient. So patient safety is the priority of both the students and the supervisor. Assessors training in the relevant workplace-based assessment tool is very important. It is not like PBL, I repeat, that a librarian can run this. It has to be an expert. Assessors' expertise in relevant disciplines and subject area is important. Program to draw on a range of different assessors. So workplace-based assessment is not done at one point of time. It is done, for example, they have to do 5 mini CX in year training or 6-month training. The 5 different assessors, 5 different situations, in ward, outpatient, emergency clinics, right? And then they have to be observed by different assessors. So that's make it more reliable and valid. Then reduces the bias. Different clinical setting, right? Feedback and areas for improvement is not the checklist, but comments are important these days, right? Now, this is, I can't see the top heading here.
Assessor role.
Okay, assessor role in workplace-based assessment, qualifies in relevant disciplines, right? That was the trainee's role. Now assessor role, it qualifies in disciplines, subject area, undertake faculty training on workplace-based assessment, ensures consent of the safety of the patient, observe critically and provides feedback, complete online form, which we will share. Hassan, I'll invite towards the end. and signs to validate, keeps the keep the clinical supervisor informed of the issues and the concerns. So the one who observe him, they will be under a clinical supervisor. So that feedback has to go to this clinical, because this assessor is not the coach, not the supervisor in training. So all in workplace assessment and competency-based medical education is very important. Assessor can be a visitor. For example, you have an exam, you have engaged an external for 5 days. Exam is going on while students are taking classroom tests and he's free. You can use him for your docs and mini CX, right? So those assessors will comments, their comments will be passed on to the clinical supervisor who are responsible for the training. Okay. Now, barriers for the workplace-based assessment is unintentionally seen as threatening, as mini CX exam and all. So students initially think it's threatening for them, low, because they feel a patient is real and situation where he is observed directly. So low rating are seen as the failures. And then for faculty, it is very difficult to rate them with realistic performance, because sometimes, your student is so well known to you and he's performed so poorly, and you want to, out of 10, you want to give him 2 or 3 marks. You do not dare to do that because you have little fear what he will feel. So this kind of biases would be in your way when you initially practice, but I tell you, over time, you will come over with this fear, right? You will be very realistic, but initially you may have little concerns. Lack of senior trainer time, right? Most of they have been running their clinic, they are busy, but they can manage is good. Informed decision on the failures. So student must be student and the supervisor must sign the checklist or the comment box where the student's performance is good or bad. They both have to agree on that, right? Otherwise, a report will go, if they say student do not sign and he says, no, my performance is not realistically measured, then he has to give his remarks, and then there will be a kind of, probing into this. So I'm not using words for supervisor, their inquiry or something. There will be a probing, because it's very important these days that the teacher, students maintain a very good relationship, because this is very important for reflective practice and the feedback. So provide faculty development, one way of solution. Promote workplace-based assessment for learning, provide written feedback, and bear with the low scores as the norm early on, right? So low scores as the norm early on. Students will also improve as they take on more workplace assessment tests. Provide time in job for workplace assessment. That has to be little compromise on busy clinicians. They have to do that. Now, reliability and work and validity. Now, remember that it is enhanced by assessors training, right? Reliability will be enhanced. You train the assessor. Use of a range of assessors, multiple assessors, use of various workplace assessment methods. Mini CX don't marry to one tool. You can use multiple tools. More frequent use at least mini CX and docs too. And postgraduate case-based discussion is a very good tool. More, and now I recommend you triple jump. I'll introduce you that. More frequent use of the workplace-based assessment, triangulation with other assessment. Here comes a student fail, remedial taken 5 hours or 4 hours after, or 5 days or 7 days after. Instead of that, if you are having a good documented report on a student's performance over time, then triangulate those scores with his failure in summative assessment to decide on whether he should be given a benefit of doubt to pass, rather than holding random questions and few external, internal. I don't really agree with that. Most of the remedial are done the way it is done. I'm right from when I was a student, I would say I'm not happy with it. So, but you will have your own opinion. But to me, if a student's performance has been documented over time, in years of multiple years of training, those records can be utilized for decision making. For his borderline failure in summative, and I'm using word borderline, not absolutely fail should be push through those triangulation. Okay. So on validity aspects in workplace assessment, blueprinting of the workplace assessment in curriculum made it valid, meaning that when you have blueprint, you're measuring their performance over multiple skills, aligning workplace assessment with learning outcome that you have said. I'm sorry, direct observation and increasing the complexity of the task from year 1, when they reach to year 5, it should be different assessment. Demonstration now very quickly of the workplace assessment. This recording is from year 2012. So I'll give you mini CX, which is short version of the long case. It is done in 15 to 20 minutes. And there has to be a mandatory 5 to 7 minutes to be assigned or allocated for the feedback. This is very important. So they are given a patient, a real patient, students will, and then students are given one clinical attribute. In long case, they have to have examination, history, counseling, investigation, everything. Here you have to use one clinical attribute at a time. For example, I will give my student go and take history on this particular, on his, I'll give a clinical problem. He has a thyroid swelling, right? Can you take a history? And this history in mini-CX has to be done within 20 minutes. And this 20 minutes, 5 to 7 minutes has to be assigned for feedback. So this is mini-CX in nutshell, right? So mini-CX, you have to have a rating form. You have to develop your own rating form. This is one of the example was, I developed it for the University of Science Malaysia. And very quickly, I'm running through these tips. Very quickly, you see, I used to do when in a postgraduate program, I used to take 2 students, right, with consent, that one student will be observing. So I wanted to optimize because I knew that they are posting in head and neck. I was doing head and neck, then other is doing otology and rhinology and all. So patient will come to me for head and neck and thyroid. They will be trained, but to optimize, I will ask one to perform mini-CX, which is documented, and other to observe, right? Just observe so that he can learn from the other's performance. So history taking, for example, here you can see one student is performing, other is just simply observing. He is given a chance, but we do not allow more than one. Okay. So this is history taking.
So I would like to take
So
the history of the patient.
So
And almost I give you 7 minutes.
So I said I give you 7 minutes to take a history on this patient of thyroid swelling, right? So, so he will take the history, and then he started on taking the history, right? So I'll quickly move, and then here you can see the observer is using his checklist to observe, and then he is giving his feedback, right? And then after the feedback, then if you have a feedback from your patient is trained, you can give feedback to that, and then you can assign another task, and then you observe, and then you give feedback. Okay. So this is how the procedure would be. So this is, so he was given 2 tasks, right? One was history taking, and another was physical examination in mini-CX, right? So 2 tasks, he did it in, he was given, I think, 15 minutes or so, right? So this is how this mini-CX is done. Now moving on to how many core competencies can be assessed using mini-CX. Name those core competencies, because it's getting long. So I'll move on instead of waiting here, but you can give your input. So how many core competencies can be based on using mini-CX? It shouldn't be many. In 1 year training, it should be 4 to 5. Name some of those, right?
Prof, just a question. In the previous slide, when you were showing the videos, someone asked, is she real patient?
Yeah. She's a real patient, yes.
Okay.
Consent is taken. If your next question is whether consent taken or not, consent was taken.
Okay, go ahead, please.
Okay. Consent is taken from both, because I'm a medical educator. So when I made those video clips, I take consent from both patient and this student as well. Okay. But some of the clips I cannot show was very, very interesting. Their performance in real examination on patients taking history and all. Well, I cannot show because those involve some of the the personal, I would say, performance of students. So I can't use those clips. But very specialized situation indoor, I use those clips with the permission of those students who are now associate and even professor. So the 6 core skills are important: medical interviewing skills in mini-CX, physical examination skill, humanistic or professionalism, clinical judgment, counseling skill, and organizational efficiency. Organizational efficiency has 2 aspects to it, right? One is when a student come and do a history taking or perform, we have to see how organized he is. Is he very messy? Because in OSCE, I'm always wondering, students are given a seat to sit, patient is sitting in front of them, and they never take a seat. They are running around, sometimes picking up this instrument, that instrument. I'm wondering why they are doing it. Will they be doing it in the real clinic? So these are the organizational efficiency, one aspect. Other aspect of the organization, so how organized they are. For example, if they have to do, they should look at the instruments that they have to use. They should, everything is working well, then they should take a seat, introduce themselves, ask the permission, and do all. So, but rather running around, moving one end to another, I wouldn't push them for a good marks. But the other aspect of the organizational efficiency is the knowledge they have. The knowledge they have is one aspect of it, but can they use this knowledge when given a real situation is the other aspect of it. So having knowledge and using that knowledge to examine a patient is the application of knowledge. So I look at the application of knowledge in organizational efficiency. Okay, moving on to DOPS is another version of the mini-CX, but this is about the skills, and the skills performed on real or mock. We have debated on that, but this also has a, these are the procedure you see in for DOPS evaluation of master program. We developed was 42 skills, right? So imagine, can you do this within the given training period? Then unlike the mini-CX, here you have a checklist, you have a rating form, and you have a checklist. Because, for example, I have developed indirect laryngoscopic examination. But if some assessor come and I want him to do it, he may not be ready to gather all the steps that ideal will have. So we will provide them with a checklist of the procedure, right? So that he can quickly go through and revise it. But we do not use this checklist in mini-CX because history taking is what is all about. But particular procedure, I'm an ENT specialist, I'm master in all, but I need a little bit of revision of those steps so that I can give feedback. So a checklist is also prepared in DOPS besides a rating form that I'm putting them together so that you can have a message, take-home message. Okay, decision for the workplace assessment, though is full of demands in source constraint, can met with leadership and management abilities and institution investment towards it, right? So, for example, if you do not have those procedure available on real patient, you can invest on your clinical skills lab. For example, this is a postgraduate program. We have introduced this DOPS, and one of the students in year 5, this patient has come and he has been diagnosed by me for a recurrence of NPC, nasopharyngeal carcinoma, recurrence, right? Say 10-year lapse, he was normal, but suddenly a swelling and symptoms came up. So I used this patient for a year 5 students to take a biopsy who was trained with me. And so that's my observation that he can do it, right? So patient is safe.
Okay, so the NBC.
So I'm introducing him. This is a patient on MCP with the suspicion index for recurrence. So you have to take a biopsy, right? So he will brief the procedure to the patient, right? And patient knows it that he is a trainee. He's told that, right? And then I will show you the difference when you use a patient for training, giving feedback. Then after procedure, then he will be, oh my God, then he will be using the packing, nasal packing, right? And then after the nasal packing, he will be introducing his endoscope, but I'm supervising him. I'm looking at the monitor, right? If he goes wrong, I will stop him. because patient risks. I'm looking at the monitor all the time. If his instruments or endoscope goes higher up toward the cribriform plate, then I'll stop him. But as long as he's within the range of safety, I'll allow him to continue. Okay. So then after this, I'll give him feedback. Now, I'll stop here at this point, and after the feedback, this is the most important. Patient was invited to give feedback because he was very intelligent patient, right? And that you will be surprised what feedback he gave. He said 10 years back, when he was biopsied, he was in tears, right? 10 years back when he was biopsied, he was in tears. And now when he was biopsied, he didn't even feel it. This is how you train your trainees and you are confident of them. And 10 years back, just jokingly, who was the biopsy taker was my HOD. So I called him and I said, this is what patient said for you. So we laughed a lot and see that time that there are reasons technology was not developed and all. But patient said, I was in tears when I was biopsied 10 years back, but today I didn't feel it. So this is how you train, and then you give your feedback, right? Still, you may have lacunae, your trainee may have lacunae in this thing, so the feedback is provided. So this is how the DOPS is done, right? Now, case-based discussion, I will quickly go through. The case-based discussion is mostly done in postgraduate program. Undergraduate sometimes is difficult, I would say, because in case-based discussion, the idea is that the trainees, they run their own clinic under their own license, which is possible in postgraduate program. Undergraduate program, mostly the trainees work through our license, through the clinician license, not their own. So postgraduate have their own license to practice, so they practice. Then over the year of practice, when they have an exam at the end of the year, the students are asked to pick up 3 to 5 cases from their 1 year practice, 5 cases, and prepare a summary of that, right? So they will prepare a summary of the 5 cases which they want to be assessed in, right? And then a summary with the real folder is provided to the supervisor. Supervisor will go through the folder. He's given time. If half an hour exam, he'll be given those folder and this prior to exam a day or two, and then he'll go through that, and from the real performance of a student through that folder, he will pick up his points for the interview. So then he will interview the students. In so many words, he will assess the students, and then the students are, after the assessment, are given feedback. But normally in postgraduate program in family medicine, we developed this, and in family medicine, it was done on 2 patients. You can have more, it depends, because they have other multiple assessment tools. So case-based discussion was one of them. So 1 to 2 cases were used, and a case-based discussion performance is also an authentic, because they have been performing it on real patient, and based on that performance, they are done. Again, you have a case-based discussion rating form, right? And this rating form you have to develop, you have to run this. Okay, now multi-source feedback, professionalism, right, is also one of the workplace-based assessment. This is very important, that you do not only gauge their knowledge and skills, but their attitude, their behavior also throughout. It's so important that in our curriculum, if a student is questionable, or he is not, supervisors are not happy with his professionalism, he can't take the exam, right? We are not marking them with the scores, because previously we were in AUB, American University of Barbados, we used to mark them with the scores. But what if somebody scores 3 out of 7 and he takes exam and he passes exam, but 3 out of 7 is speaking of his poor performance on professionalism. So now we have changed this in our recent curriculum review. We have changed it to unsatisfactory versus satisfactory. So every student has to have a professionalism at level of satisfaction by the supervisor. If not, then he'll be barred from taking exam. So professionalism is a commitment to law many factors, competence, honesty, confidentiality, appropriate relationships, so on and so forth, right? You know that. It is important to assess the professional behavior at workplace. That's very important. Then you can use a Likert scale, which is 1 to 5 or 1 to 9. that I have shown you, 1 to 9 mostly with all the previous tools. Then anchored scale. Anchored scale in professionalism is more important than checklist. Checklist, he may pass with, gray area, he may pass. So anchored scale is where you put down the exact, the indicators, right? So it's not like a scale that excellent versus good versus pass versus borderline versus fail. This is like a scale, right? But behaviorally, when I say anchored, you have to identify when you say excellent, what is excellent, what is good, what is fail or borderline. So that is behaviorally determined anchored scale, Likert scale, anchored scale, and one is the checklist scale, which I showed you 1 to 10 or 1 to 9 points. In professionalism, this was my research grant at national level. So this was how we proceeded on. So we first we identified the competencies, intercommunication skill, professionalism, social skills, leadership skills, and all. Those were put to mark their professionalism. Then competencies that fit in each specific behavior was listed, right? So, and then a checklist was prepared. But remember that here, who would provide, I'll show you, who would provide the, would be the evaluator, faculty, nurses, trainee peer, patient, simulated patient, and medical assistant. We have used, this patient was a real patient, which I showed you in the docs, was a very intelligent patient, was allowed to give their feedback on a student performance, but they were kept into 3 areas. Or these areas here, but 3 was more important. Confidence of the student, they will talk, not about the knowledge and skills. Confidence of the student, patient care provided, were they feeling pain and the students were proceeding on, or they were given time to relax and, so patient care, politeness and respect, clarity of questioning, when patient asked question was clearly answered, clarity of instructions given to do the procedure, and trust to be examined again by the student. These are the 6 aspects where patient will give feedback, but they are trained to give it. We do not trust every patient. Patient has to have a literacy level, and then they have to have this, right? So this is how we do. And then going back, you will see in this, when it is about, does the trainee introduce himself and greet the patient? So who would give? Right? Who would be the best person to evaluate? And how much marks? So every checklist point item has 1 mark. So sometime we divide it into 3 assessors. For example, in that case, in DOPS, there was 3 assessors, myself, another assessor was a nurse, another was patient. But for me to mark would be, as an assessor, would be 0.5 out of 1. Nurse would be 0.25 and patient is 0.25, but trained patient, and his areas determined from that. So this is how you do. Is a cumbersome this thing, but this is my research project. So I did it, and then it is implemented in one of the schools. Okay, so this is how you go through e-portfolio now. E-portfolio are the collection of evidences of the student's performance, collected either as a hard copy e-portfolio or digital portfolio. You can develop digital portfolio using your Google Doc shared file. You can use the Moodles, you can use LMS. So all this, I'll pass on this to Hassan later to explain how is it. So this is how these evidences are collected, right? And those evidences are used for assessment actually, right? So now next is the reflective practice. Reflective practice is very important. It's also one of the assessment tools for workplace-based assessment. So we give them a Gibbs model where they have to have what happened. So event, if supervisor is the one who you are sending this reflective practice, you can just tell a session with you, a session with Dr. Shahid, right? But don't have to explain the event. But if somebody else who is not was present in that event and you're sending this reflective practice, you have to describe the event in detail. Then feelings, what are you thinking and feeling? So at the time when the event happened or the encounter, with patient happened? What was your feeling when I gave that student to give the do the biopsy for the first time on a real patient as an assessment, right? As a workplace-based assessment tool. So you have to be very careful choosing a patient for the real patient undergoing workplace-based assessment in procedural skills. Okay. So what was the feeling of the student, and what was good and what was bad about that experience that he had, right? So that is evaluation. Analysis would be what sense can he make of this situation after having done it. He will analyze what was learning point here, what did I learn, and how can I improve and all. And conclusion is, what else could I do it when next time the same procedure is done, and what would be my further action plan if I have an experience or opportunity to do it again. So this is how we give the students reflective form and feedback form. So feedback form is mostly on the, I just given an example randomly picked up this morning from one of my teaching, micro teaching feedback. And then this is the reflective writing they had to submit, right? If there is something from my feedback, then I'll give. So this is important. Portfolio, what is a student digital portfolio? I'll not hang on here because time is important for you all. You must have been tired. I'm taking a long session here. I don't mind if you are ready to interact and also. What is the student's digital portfolio? Name the type of assessment portfolio can be used. So let me move on. So a portfolio is a collection of evidences over time, and that can be used as formative assessment, summative assessment, or self-assessment and peer assessment. You can ask. So for us, a portfolio, it is very important who is authorized actually to be allowed to have an access to the portfolio. So this is on the candidate or institution. Usually supervisors are allowed, and some of the mentor will be allowed, not more than that. But some institution allow parents also. Some institution will allow an identified peer also to give feedback on that. So digital portfolio will be same thing. Develop a collection of those evidences by the students over time digitally, right? Using a Google Doc on you see as a shared file. You can create that file for them, a folder for them, and they can dump in all those evidences, and then you can use a supervisor who has taught them, and you can use an external supervisor also given access to give their opinion. So that's very important. In postgraduate program, you use it with the external assessors to do that. Okay. So this is how it is done. Triple jump, my favorite. So the triple jump is a type of assessment that evaluates the student's ability, right? What happens is that it's a very interesting tool. So you can do it in year 1 until year 5. The student in year 1 come, we know it's an integrated program. They have learned through the basic sciences, anatomy, physiology, biochemistry and all. But I want them, since it is integrated, I want them to have an early exposure to the patients. So I will ask them that I give you a clinical scenario, and I give you maybe 2 days, 5 days, or 7 days, right? I give them usually year 1 student, I give them 3 to 5 days. We have 3 to 5 days to work on this clinical problem. So they will discuss the clinical problem with me or with the supervisor, and this supervisor will also tell them if it is more about pathology. So you say your resource person for this week in triple jump is Dr. XY in pathology. So a resource person is provided, but it is up to them to go online, to go library, to go any resource person they want to. But after what they have to do is they have to collect they have to identify the learning issues after having discussed the clinical problem with the clinical problem, right? So when I say clinical problem, it is just one-line statement, not the complete history and all. So like patient has a thyroid swelling with last 2 weeks. Go and tell me what are the likely diagnosis in this patient, right? So not more than that. Then he will go, patient is not, this scenario is given, they have to develop their presentation by working on through the resource person, going to the library and working on what a thyroid swelling patient of the 2 weeks duration will likely have, okay? Then, so first step is here. The first step is called the problem definition, approximately 15 minutes discussion with the students by the supervisor, define their problem or generate the hypothesis, right? Generate the hypothesis, and then in step 2, they will is called the information search and study. So they go and search and study, and then step 3 is their formulation of the final hypothesis. So they generate a hypothesis. When I use this term, generate hypothesis, mean develop differential diagnosis, for example, right? So thyroid swelling 2 weeks, what are the differential diagnoses? But they have to reach to certain diagnosis in the given scenario, what is the most likely? So I'll give them a picture of that patient, maybe, or just one line statement. And then they have to work on this and formulate their hypothesis. And then they come all, and yeah, mind you, I forgot to tell you, if the students are, say, 20 students are posted in my clinic, then I'll divide them into 5 groups, 4 each. So they are divided in a small group and they work, and then they come and present. So they learn from each other. This is triple jump. So if I have to, in effect, infographic, I have to show you, first step is problem definition. Second is the pursuit of the information and collecting the information to solve the problem. And third is their formulation and presentation, okay? You will like it doing it. So in conclusion for today's session, is workplace assessment and competency-based medical educations are a paradigm shift led to a new trend of competency-based assessment aligned with competency-based assessment, which in so many words is workplace-based assessment. The major development in competency-based education should not lie in the design. Don't focus too much on the design of the instruction material, but in the design of the appropriate performance assessment, right? Develop your assessment of the milestones, right? So how would you observe the EPS? More is on that. In a competency-based medical education, faculty development in competencies framework is very important, okay? So if I have to put it in infographic, I would say the curriculum is to be taught and then assessed in knowledge, psychomotor skills or performance skills, and attitude. And this, for their skills performance, they have to be observed. And they have to observe through the EPS, which is nothing but task in working, right? So entrustment has to come from the supervisor. So when that entrustment has come, it will come through a milestones rubric I have told you, where the supervisor will say he is level 1, level 2, level 3, or level 4 or 5. Level 1 is not in question because it's just first exam observing him without coaching. Level 2 is proactive. Level 3 is reactive supervision. Fourth is the level where remote assessment can be done, remotely assessment can be done, rating can be done. And 5 is level where they can teach the junior. So I will assign using these milestones for attainments of the EPAs at the level of their training is also so milestones have got 2 components: attainments of those using a rubric 5 levels, and then attainment of that at level of training you have to mention also year 1, 2, and accordingly you have to develop your skills or competencies, right? Workplace assessment is the best tool to actually run competency-based medical education. There I end. This is my thank you to you, all of you, for your participation. And then this is my contact. You can contact me through this email, on personal email, or you can contact me on LinkedIn. Okay, with this, I pass on to Hassan to actually a little bit talk on, if time allows you, I will show you something here we are working on. You see, this is our workplace-based assessment. We are working on this if we have to use this for training. So this is checklist-based version 1, and this is, Hassan will talk a little bit on that. And the other is the component. No, this is your post-test. So Hassan, can you, meanwhile, when we are running this session, can they do post-test?
Sure, Prof. Let me post
so
the
this
link.
Is, yeah. Hassan, later on you talk on this, right? This is checklist based and this is comments based, right? So he will talk. Okay.
Right, can I ask something? Right?
Yeah. You please, question answer session is on. Meanwhile, you keep doing your post test. Yes. Kaisa Sijat. Yes.
Yeah, but I just want to know you said what is romantic assessment, something I can't hear you properly, the level of assessment you said in the end of the
Okay.
conclusion.
I'll explain that. Okay.
Okay.
Kaisa Sijat and all. You can use 5 level rubric for assessment of the EPAs or task in working or competencies of being observed through milestone. So level 1 is when you just observe and do not execute. Do not execute means you do not provide your input or give your coaching. You just observe them, right? And see, and then you record their performance. This is level 1, right? So
Yes.
you determine that, but say, for example, a student you are observing has performed excellently well. So you will put him, though you were observing him for level 1, but he performed at level 3. So you have to put down that he has already attained a level, maybe he has trained already with someone. So anyway, so level 1 is when you just observe and you do not execute, do not do any coaching. Level 2 is a proper coaching, which is called proactive supervision, whereby you will train them, you will ask them to perform, you will feed them, then will again ask them to perform. This is proactive. Reactive is one, after you are satisfied they can perform, they will go and practice on their own several times in a skills lab, but whatever on real patient, and they will contact you to be observed, right? This is reactive supervision, right? This is what you missed out. So reactive supervision. Then 4th is the distance supervision, remote supervision. For example, somebody has performed, you have video recorded them and you are giving feedback on video recording, yeah, or you are observing them from a distance that trainee may not know it or whatever, right? So those remote supervision is also level 4, and 5 is where your students can train or can teach the juniors. So you have so much confidence in them that you can say he is a perfect peer for the peer teaching of their juniors. So this is level 5. So 5 levels you can attend, and you will have the recording of this session. So you can go thoroughly through those. You can stop over at those rubric and can develop for your own. You can modify it a little bit on your own. Okay,
Thank you very
I'm
much.
clear.
Sir. Thank you very much.
So keep doing your post tests, right? And then, oh my God, my wife gave me a cup of tea. I didn't realize.
Yes,
Hassan, over to you.
yeah, thanks, Prof, for a wonderful session. A lot of positive feedback from the participants, and we still have around 50 participants still around, no? So that's
Okay.
great. So I have shared actually the link of Sadiq International Virtual University homepage. So please feel free to go to that page, and all the recording of all the sessions are uploaded there. So there was a question, Prof, if you could highlight the difference between undergraduate medical education and postgraduate medical education mini CX, if there is any difference.
Okay. Good question again, because these kind of question always bother our mind. But you see, when we do it, even at the undergraduate level, training year 1 to training year 5, our mini CX will be of different complexity, right? For example, in year 1, we will just ask them to take a simple history about their having a problem, a clinical problem or whatever, right? So you start on that. Then you keep adding complexity to those as they proceed on from year 1 to 2 to 3 to 4. But mostly we start our clinical teaching, full-blown teaching is a semester 6. If it is 10-year semester, 10 semester program, 6, or in year 3. So if that be the case, so you make them learn or practice history taking and other examination skills in mini CX. In year 1 and 2, and in year 3, when you proceed to year 4, you add little complexity to it, and then year 5, right, to the same clinical condition. You may have concomitant problems put together but when it comes to postgraduate, you already start from a point where you know they have already graduated in with MBBS or MD program or residency, for example. So, or if they are doing fellowship. So as you move on higher in training level, your complexity of those mini CX would be at that level of their requirement. Because it's very important whether your program is assigning someone to be a graduate with MBBS or with a family medicine postgraduate program where he will directly next day will be sitting in community and handling the patient. Whereas I know my undergraduate will first will do internship for 2 years, so there is ample time for them to learn. So they will learn there. But once they are in postgraduate program, so you take off from that level of understanding that they have done undergraduate. So not very simple cases to start on, but with little more complex cases. So postgraduate will be at a different level, a level of their training of different complexity. Yeah.
Yes, I think Dr. Mavi Ahmed raised hand, and that would be, I think, our last question because of the time. Yes,
Okay.
Dr. Mavi Ahmed, you can unmute, please.
Thank for this very informative and it is really a benefit. But I have a question on undergraduate level, maybe 2 questions, but very short question. Can
Sure.
we mini CX or workplace assessment to replace OSBI? Can they replace OSBI? The other question, what about
You mean OSCE? You mean OSCE?
OSCE, sorry, yes, sorry, OSCE.
Okay,
Yes,
okay,
sorry. Okay. And the other question, there is debate even in our school that in mini CX, when you use it for summative assessment, it is not fair because one student may encounter one case and the other student may encounter another case. So what's your opinion? How can you advise us?
Okay, so my opinion, if you stop the recording, I'll give my frank opinion. But still, I'll keep to some of the norms to be observed and give my opinion. I think I was very explicit in my opinion on introducing OSCE and replacing long cases, right? OSCE in the name, why OSCE was so popular? Where in long case, you have holistic test of a student's performance. In OSCE, it is segmented, yet become very popular in the name of standardization, right? You are bringing the same issue in workplace-based assessment. So if you want that everyone get the same case in workplace-based assessment, it's not possible, right? You will not get the same case, otherwise your exam will run over many months if the same case you use. Is not possible. But in the name of standardization, you are moving on again to introduce some instrument which will be a compromise of the workplace-based assessment. Similarly, I'm giving a very clear example. Long case, such a good assessment tool was made obsolete. Nobody, and it's time to revisit long case, I always say, has been replaced by the OSCE. It came from the stalwart medical educators. I do not want to comment, but in the name of standardization, the segmentation was done to the competency to be achieved by the students is not a take which I will be happy with, right? That's my say. So similarly, if you want mini CX to be same in the name of standardization, then you are bringing something which I have very clearly given my expressions about when you make assessment very segmented, very standardized, then there is a lot of compromise in its validity, right? Your assessment has to be valid and reliable. In the name of standardization and validity, we have a lot of compromise. I can't speak more than that if the messages went across well. What is your second question?
And the second question.
Yeah, your second OSCE. Can OSCE replace the mini CX and all? Remember, can anyone?
The other way, sorry for interpretation. The other way, can we replace OSCE by mini CX or workplace assessment?
It's same. Either way, it's a very intelligent question. And if somebody can answer, then it needs your understanding with the OSCE and then answering this. If not, then I directly answer. Okay. OSCE is a multiple stations whereby there are small stations where you can bring in any sort of the exam assessment within that stipulated time, right? So short case, for example, you can bring in OSCE, right? OSCE is a multiple station assessment. So you can bring it your mini CX in OSCE, but not the other way around, right? You get my point? So mini CX can be brought in OSCE because say if you have 10, but in OSCE we do not have that time. But if you have 10-minute station OSCE, a mini CX or DOPS can easily adopted or accommodated in OSCE, because OSCE has multiple station with variability, right? A lot of variability. You can have short cases in it, you can have mini CX, you can DOP, but that is normally not practiced, because mini CX and these are practiced because the point will be that you cannot bring so many real patients, authentic patients, and then different patient in different station will compromise the standardization, which is the mainstay of the OSCE, right? So OSCE will be compromised here, but I'll be happy. But OSCE will be compromised here because standardization cannot be observed, because you cannot have 10 stations on similar patient or the same patient being used time and again. It's difficult. But nevertheless, OSCE station has the room for accommodating mini CX and DOPS and other procedures, which is within limited time can be performed. Am I clear?
Yes, thank you, sir. Thank you, sir. It's very informative. Thank you.
Okay, Prof. Due to time constraint, I will summarize. There is actually someone object to your suggestion just now, like including mini CX or DOPS in OSCE. Two different approaches he was saying actually. But
let me clear. This message went wrong across, right? These are two different approaches, right? Two different approaches. But when you are bringing mini CX into OSCE, then it is not mini CX. What I mean is that mini CX procedure can be accommodated OSCE, but it will remain OSCE station 1, 2, 3, 4, 5. It will. You cannot call OSCE mini CX, OSCE DOPS. No. I think there was little problem with the understanding and message went wrong across. So what I was answering was that mini CX procedure can be bring into OSCE. For example, you are doing day and night in OSCE. You ask a simulated patient is sitting there, and you ask a student to take history. What is this? This is a mini CX. You ask him in a station to examine his neck. This is a DOPS, right? So you can do that, but then you are not fulfilling all the criteria of real patient is not there, right? You are using a mock patient. So you cannot talk it a mini CX OSCE. It is still OSCE, but mini CX procedure can be brought in. So I think before you, I think you should have a cross question to clear this point. But I hope it's clear now.
yes, Prof. Okay. Maybe we can do one-to-one session, no issues in discussion and elaboration.
Yeah, these questions are very good, because this tells us about assessment. As I always say, is a lot of compromises in assessment. So in assessment, we have a lot of questions, lot of particularly when we are practicing it. So those can be done where I agree with you. There should be a forum, discussion forum, where we can discuss all this. Yeah, that is possible during the courses.
Sure.
Sir, I have a query, sir, for.
Please introduce yourself. And
I'm Dr. Muhammad Asif, sir, from Gujranwala, Pakistan.
Please go ahead.
Oh, Asif, yeah, I know you, Asif. Yes, come on with your question.
Sir,
you are attending the diploma program, right?
Yeah.
You are attending postgraduate diploma from SIVU and ERA?
Yeah.
Okay.
And my question, these many CX and DOPS, usually these are in the formative assessment, and the OSCE is usually in the summative assessment.
Yeah.
What we are actually doing, it is just like formative assessment, mini CX and DOPS, and summative assessment, we are taking these OSCE stations.
Let me clear. Yeah, I got your point. Yeah. So first of all, formative and summative, if we live with those definitions, we can never move on. So programmatic assessment, if you look at, which is getting popular and many schools are adopting, programmatic assessment is this formative assessment done over time, say in a year program, and then those formative assessment are assessed for summative assessment by another. I think I have repeated it several times in my postgraduate program, also here, also in the earlier on in this session, that those formatively assessed are not used for decision making at that point. Nobody is pass or fail, right? So keeping with the sanctity of the formative assessment, we still are diluting the border between the formative and summative. That at another point of time, we are using those collated formative assessment for a summative decision. But this decision comes from our assessment committee, which is not involved in supervision or teaching or instruction. Okay, so that's one point. So OSCE is OSCE you can use. It's your option. OSCE you can use for formative, for summative both. Don't kind of restrict yourself with these definitions of summative and formative. There was 2 slides in my presentation. I removed them this morning because when we teach through slides, the message goes, you have a visual impact also. So you will have formative and summative. There were the 2 slides, I removed it because formative assessment is to give the feedback, basically, right? And not to take decisions, so that it is not very much kind of nightmare for the students, so they feel relaxed and they do it. But if you use formative assessment over times, give them feedback, but do not make a decision on that, then it still remain formative. But another point of time, when so many of formative assessment collated in that program in 1 year, you use them for summative assessment. So keep little bit your options open for your understanding and practice of these terms. So programmatic assessment works with I say dilution of the boundary between the summative or formative assessment. But
that is my point, sir. That is my point. That is the feedback is the mandatory part of the mini CX and
correct.
Then
yeah, that's
it can't be used for a summative assessment then.
Yeah, you're right. You're right. But if we give them feedback, it's good enough. But if we use that for a decision making, that on one mini CX, we say he's failed, right? Now we ask them, and that was the time when he was supposed to move from year 1 to year 2. He failed 3 mini CX, and then we take a decision. This is not formative assessment, right? Formative assessment because we have taken a decision on that. But I'm telling you another aspect of it in programmatic assessment. These 3 formative assessment, when done at different point of time, and when these are used for summative assessment toward the end of the year, then there'll be a decision on formative assessment. So now the question will arise. People will say, this was formative, why you made a decision? So this is what all the stalwart in assessment are working on. We have been engaged ourselves. We have been engaged in engage ourselves with the formative and summative definition. This is how we teach, and the students capture the concepts, and then they practice, and they are very rigid in their concepts because the way we teach. So I am telling you, the formative and summative assessment boundaries should be considered slightly diluted, if not fully, and use formative. Even in mini CX, many schools are using it for summative assessment. But how they are using it, they do 4 to 5 in a year program, the mini CX as an formative, but end of the year, those 4, 5 will be used for summative decision. I hope you get my point. But it is up to you how you want to practice it. But literature allows you now to not to be very rigid in the boundaries between formative and summative.
So Shahid, allow me to say before Hassan concludes, that wise men can seldom agree, fools hardly ever disagree. So you're a collection of wise men, you'll never agree.
Your comment is so precious and so nail on the head. Actually, thank you very much.
I'm watching it regularly and attending to all your sessions and things. But see that the higher the level of intellect, the higher the level of arguments, debates, not argument, debates, discussions, etc., with a view to learn. And that is the quality of education. That it is something, a source of inspiration of your soul. And that's exactly what you're doing. It was a phenomenal lecture. I thoroughly enjoyed every word of it. I mean, this is beyond me in a way because I've lost interest in the proper day-to-day teaching. I'm not doing that. I just do ENT clinics and a bit of audiology and other things. But coming from experts that I've seen in the whole lot of people, it's been a phenomenal. Over to you, Hassan, you wanted to show something about digital, and then
I think due to the time constraint, it's over already for more than 20 minutes. So maybe I can give it to you to conclude this session. There are even few more comments people wants to argue and discuss and debate. So I think Prof. Shahid already shared his personal email. So you can always be most welcome to discuss. So maybe we can conclude this session.
Yeah, I think Mubashir has an announcement to make about the postgraduate diploma. Over to you, Mubashir, before you conclude.
Yes, sir. Thank you, sir, for all of you. You may know that Al Sadiq International Virtual University runs courses.
You want to share the screen? You want to share the screen?
It's okay, sir. I'll just announce here because I don't have anything to present. So I just wanted to remind and share with you all that we have upcoming courses in postgraduate diploma in health professions education, and we may be starting the masters of the health professions education from this year, which we have not finalized, but postgraduate diploma and health professions education certificate course over the period of 6 months, and the postgraduate diploma is over the period of 1 year. So all of you, you can wait for our email. I hope within the next couple of days you'll get the email notification of our courses, and you may share with your colleagues and people who are around you if they want to participate with us. We have limited seats for both the courses, and looking at the success and the way we have taught the previous 2 classes, 2 batches, I think it is quite credible and quite a sophisticated course within that particular small fee. So I hope you will carry this message across. Thank you all. Thank you, sir.
Also, the announcement that the book called Global Medical Education in Normal and Challenging Times, published under the chief editorship of Shahid Hassan, of course, associated with Sholeh, Tabassum, and myself, is now out. It's published by Springer. And Springer, as you know, is a famous publishing house which produces high quality stuff. We really had to go a very thorough checkup, painstaking process over a period of 2 years. But thanks to all the scholars from Sadiq International Virtual University from across the globe. And I think we still have some material left over, and we might consider to publish it through another publisher in the future. And that book is now available on Springer's webpage. With those words, I thank you all on behalf of Sadiq International Virtual University that you've all given so much of your precious time at the weekend. Thank you, and see you again. Thank you, Hasnan, and thank you
everyone.
Thank you, Shahid.
Thank you, sir. Thank you, sir.
Thank you, sir. Thank you. Bye-bye.
Thank you, Hasnan. And thank you, everyone.
Bye.